Assalamu alaikum. Thank you, Dr. Amr, for inviting me with you today. Thank you, Dr. Kamal, before leaving. Your talk is great. Dr. Abir, your talk was rich and magnificent. Dr. Naha is not here, but tell her for me. Thank you. Please tell Dr. Naha for me I'm speechless. Dr. Tamer, you helped me a lot. I can now say goodbye and see you next year. But I'm going to talk in a different scope. First, I'm going to ask a question for the young assistant lecturers of hematology. How many times do you perform a plasmapheresis or cytopheresis? How many times a week, a month? I don't know. How frequent? Many times. How frequent? How frequent? Once a week? 12 sessions per week. I'm going to ask our assistant lecturers in pediatrics, how many times do you perform apheresis? Have you ever performed it? No. Do you think it's fair to deprive children from such a therapeutic modality because they are just tiny humans? I don't think it's fair. It's not fair. Let's see what is the problem. Today I want to answer two questions. The first, what are the risks of apheresis in children? Why we avoid them? Why we are so scared of performing apheresis in children? And what are the benefits? And at the end of this talk, I'm going to say, is the risk is greater than the benefit? That's why we avoid it, or what's wrong? Let's start. As Dr. Nuha said, apheresis means to take away. What are we going to take away? We are going to take away either cells by cytopheresis or plasma component by plasmapheresis. I was asked about the basics of apheresis by some of the undergraduate students here. The idea is that blood is not homogeneous. It can be separated into different components, the liquid part and the cellular part. The liquid part is the plasma, and the cellular part can be further subdivided into erythrocytes, area for granulocytes, monocytes, lymphocytes, and the platelet interface between the liquid and the cellular phase. According to this, we can separate these different components and use them or remove them. If it is simple, how it is performed. It's either manual or automated. The doctors of internal medicine may be confused when they hear about the manual method, but we are familiar with the manual method. You said you have never done apheresis procedure, but all of us in pediatrics do it. We do the manual procedure. We do it in the unit, the manual exchange transfusion. This is a form of apheresis. We are doing it manual and interrupted manner, not using the automated and continuous machines. If Dr. Noha was here, I was going to tell her that this is the first apheresis machine. She was grateful to this machine. Do you know that we owe this machine to children? The first invented machine was invented by an IBM engineer from the international IBM company. His name was George Judas at the year 1962. This machine was inspired by his only child. His child had leukemia at the age of 15 years. When they were visiting the National Cancer Institute in California, the child noticed that there is frequent need for platelet transfusion, and every time they extract the platelets by the manual way, they take blood from donors, centrifuge it, and separate platelets, and either they return the blood to the donor or use it for other uses. He suggested the idea, why don't we start it a mechanical way? Why don't we invent a machine? And his father invented the first apheresis machine at the year 1962. What is our problem in pediatrics? Every time when I was a resident, when I asked for apheresis for a patient, the answer was always, the child is too small to be put on a machine. Can we answer this question? How small is too small? What do you think? How small is too small? We were told that 20 kilograms is the minimum body weight that can be put on apheresis machine. But the literature say no. We can put as small as 5 kilogram babies on apheresis machines. We don't use it. We are wasting a wide range of therapy for our children. So what is the problem with the children? Again, why don't we use it? What are we afraid of? We are afraid of the problems associated with anticoagulation, the problem associated with the venous access, hypothermia, the rapid volume shifters, and not to mention patient operation. Imagine you are putting a baby or a 10-year-old child on a machine, connecting him to wires around him, and saying you are going to be like this for 2 or 3 hours. The patient operation is a real problem. Starting with the vascular access. We all know that insertion of a vascular access in children is a life-saving and difficult procedure. The vascular access is a cornerstone in the process of apheresis. It depends on how urgent you are going to perform it, the frequency and duration of apheresis procedure, the patient comfort, and ease of caster. All of these are going to affect our choice. Are we going to choose a peripheral or central access, arterial or venous, single or double lumen, temporary or permanent? And accordingly, we are going to choose a catheter. The usual catheter we use as a central line in pediatrics cannot be used for apheresis. We have to use double lumen supported catheter like those used in initial hemodialysis, because the lumen is supported so it cannot collapse under the negative pressure of the withdrawal of the machine. The femoral catheter is the easiest to insert, but the highest rate of complication is associated with it because it's more liable to infection. It leads to patient discomfort. The subclavian and the internal jugular are a little bit more risky at insertion, but they are easily used, can be taken care of easily, and less complication rate with them. After the vascular access, we face a problem for anticoagulation. The blood withdrawal from the patient into the circuit of the machine must be kept liquid. We use citrate. The use of citrate has special problems in the children because it absorbs all the ionized calcium from the blood. The problem, especially in the children, is augmented by 3 factors. The first is that apheresis machines often needed to be run at a minimum rate, giving citrate a longer time to work on the blood and consume more ionized calcium. Besides, critically ill children already have low ionized serum calcium level. The third factor is that most of critically ill children are exposed to hypoxia, and the hypoxic insult lead to hepatic dysfunction that affect the detoxification of citrates. We have to be very careful when dealing with a child on a apheresis machine, because citrate toxicity cannot be expressed by the child. He may be unable to say that I have circumpolar tingling, and it can advance in few minutes into life-threatening cardiac arrhythmias and cardiac standstill. So the child cannot express himself. I have to search for the toxicity. I have to monitor the child, measure ionized calcium before and after the procedure, and keep an eye on him. The volume shift. The volume shift means that I'm going to take blood from the patient into the machine, then return it. It's either in an interrupted manner. In this way, I'm going to induce hypovolemia in a child, so we don't use the interrupted way on the apheresis machine in children. But this is not the only problem. The problem is, if you imagine with me, a 12 kilograms weighing child, his blood volume means 12 multiplied by 80 is about 800 milliliters, and the machine can adopt up to 400 milliliters. If we start the machine on this child, I'm going to withdraw about 50% of his total blood volume. Do you imagine this? This is going to be disastrous. 50% of the blood volume of a baby is going to be in the machine. We can't do this. So we have to prime the machine. Priming means I am going to fill the external circuit with backdrained blood cells. This is a mandatory process, especially if I am going to withdraw more than 15% of the total blood volume. Not only the withdrawal is a problem, the other problem is the rapid return of the fluid into the circulation. The machine withdraws it at a certain rate, but at the end of the procedure, it pumps it rapidly into the circulation, which performs a volume overload over the baby's heart. That is a problem with the volume shift. The third problem is hypothermia. I saw the apheresis machine at your unit, in hematology unit, and I saw patients, they are sitting with blankets on them. Even adults feel cold. Imagine the child. The child is more liable to hypothermia, and the hypothermia in the children is very critical. It can lead to fatal cardiac arrhythmias or severe metabolic acidosis that the child cannot withstand. This is related directly to the ratio of extracorporeal volume to the blood volume. That is why we try to use less extracorporeal volume by priming the machine. It's also related to the rate of blood removal. That is why we run the machine at the minimum rate. And the thermal properties of the system. Some machines are provided with a warmer. But the problem with the warmer is that it's going to keep the temperature stable on the expense of withdrawing more extracorporeal volume. Lastly, we have to be careful when dealing with a child. A child on apheresis machine needs initial monitoring every 5 to 10 minutes. This can be wider spacing after starting the procedure. We can monitor the vital signs every 30 minutes. Continuous cardiac monitoring throughout the procedure is needed. Serum ionized calcium and other electrolytes and maybe arterial blood gases may be required before and after the procedure, and special attention to citrate toxicity can be prevented by continuous infusion of ionized calcium. The guidelines here are the same as Dr. Tamer said and as Dr. Kamal said. It's the same in pediatrics, category 1, category 2, 3, and 4. Most of our pediatric indications lie in category 2 and 3. And let me say that if we're going to talk about category 3, it's a heroic effort to treatment. Think twice before doing it. There is much safer procedures, especially when we are talking about the children. In hematology, apheresis can be either cellular or plasma exchange. I'm going to talk rapidly about this because it was well covered in the previous lectures. We use erythrocytapheresis for polycythemia, hemochromatosis, and removal of abnormal red blood cells. The most common indication with us is sickle cell anemia. We use apheresis for sickle cell anemia either in one of two fashions. First, we do it in acute setting. The target of the acute apheresis is to remove hemoglobin S and replace it by hemoglobin A in a condition where a sudden vascular event has occurred, like a stroke or vaso-occlusive crisis. The second way is to use it as a chronic therapy, a chronic transfusion regimen, to maintain hemoglobin S below 50%, and in some literatures we say that we need to keep it below 30%. This is specifically indicated for patients with previous overt stroke. But the most common are the Erythrocytapheresis for acute chest syndrome, stroke, priapism, preoperative transfusion for general anesthesia. We also use erythrocytapheresis as a method for isovolemic red cell transfusion. By isovolemic, I mean the patient is severely anemic, but he cannot withstand the transfusion of RBCs. So I'm going to give him RBCs and remove from his circulation the excess plasma and the excess acellular component. We use it in thalassaemic patients with end-stage cardiac failure, and we use it also in overwhelming hemolysis. Methemoglobinemia is also an indication in pediatrics for erythrocytapheresis if the first-line therapy fails. Leukapheresis, on the other hand, is very important for a special category of patients which are the leukemic children. Leukemic children with hyperleukocytosis are susceptible to vaso-occlusive events and tumor lysis syndrome. So we need to remove this harmful large number of leukocytes. But this is not the only function of leukapheresis. We have a more important function for leukapheresis. We use leukapheresis for peripheral blood progenitor cell collection. Now it's a routine step in the treatment of some cancer patients. For example, in the Children's Cancer Hospital, they use it as a routine step in the treatment of stage 4 neuroblastoma. After the first 2 cycles of chemotherapy, they put the patient on apheresis machine, collect the CD34 positive after giving him chemotherapy and GCSF to increase the number of CD34 positive cells up to 100-fold. These are going to be used later on for autologous transplantation. They are going to be preserved and reproduced to the patient after the end of chemotherapy. This is a future hope for many children for allogeneic stem cell transplantation. The last is plasmapheresis. Plasmapheresis in hematology is going to be used like other adult patients. It's going to be used in autoimmune hemolysis, purpura fulminans and DIC, thrombotic thrombocytopenic purpura, as Dr. Noha said, coagulation factor inhibitors, post-transfusion purpura, and the APO-incompatible organ or marrow transplantation. Till now, I'm talking about hematological indications only, but to be honest and fair, the hematological indications for pheresis are not the most important indications in pediatrics. There are more important indications which include Goodpasture syndrome, Guillain-Barré syndrome. Guillain-Barré is very common in children, and it's treated by apheresis, and it gives very good results. Also, homozygous familial hypercholesterolemia, myasthenia gravis, Revson disease, Wilson disease, and other indications like rapidly progressive glomerulonephritis, chronic inflammatory demyelinating neuropathy. It can even be used in acute poisoning in children, especially in the poisons bound to plasma proteins. Dr. Aisha can tell us about this. Also, it's used in hemolytic uremic syndrome, pemphigus vulgaris, and systemic vasculitis. But we have to be very careful when dealing with a child. We have to wait for these side effects and be ready to deal with it. All side effects are similar to those in adults: citrate toxicity, vascular complication, vasovagal attacks, hypervolemia, allergic reaction, hemolysis, also air embolism, depletion of clotting factors and immunoglobulins and other plasma proteins, and circulatory and respiratory overload. Lastly, in conclusion, I'm going to say that therapeutic apheresis in children is a risky procedure. If it is going to be performed, it should be performed by the most experienced senior staff in the center, and we should anticipate the risk, be ready to manage adverse effects. Only then we can do it. Thank you.